Okay, everybody, welcome. Okay, we're just going to turn off our speakers. Or turn them down. How's that? Better, okay. Okay. Welcome, everybody. Thanks for joining us today at our Provider Fast Track Information and Feedback session. This is our third session, and we're going to be having another one next week. If there's anybody that you know who might be interested, they can go ahead and email us, or you could forward them the invitation. I just want to introduce who's here, and then we can ask you guys, we'll introduce who's joined us online as well. So my name is Lynn Kaplan. I'm the LifeNet Project Director here at MHA. This is Lisa, who is the Director for the Center for Policy Advocacy and Education. Diana Jimenez, who is our Crisis Counselor for Provider Fast Track. Gail Bauer, our LifeNet Program Manager. And Ann Ahern, our Administrative Support, who's going to be taking some minutes. And as I mentioned, we're recording this conference, and we'll be posting it online. So that will be another place for people to come and get the information. So we'll get started. Sent out the agenda, and I'll just go through it one more time. So we're going to start out with the introduction of the Provider Fast Track referral process, talk about an overview of the form, discuss eligibility criteria for each of the different mobile crisis types. We'll present the Fast Track referral form. We'll talk about alternatives to Fast Track, or alternatives really to mobile crisis referral if it's not meeting the criteria. We'll have some information about what's going to be happening moving forward, and then we're going to leave time for discussion. We really want to hear from you guys, your feedback, and any questions. So we're really looking forward to that. If you do have some questions at the end of each section, we'll also take a few questions which you can write in the chat, and then we will answer them at the end of each section. Just a couple, and we'll leave the most time for that at the end. Okay, so introduction and Provider Fast Track. So we started the Provider Fast Track in February 2015, and we introduced it to really improve the mobile crisis team referral process. We know that people have been really waiting on the phone, and we really wanted to change that and make it a much quicker and easier process to do a mobile crisis team referral. So that's part of why we introduced it. We streamlined the referral process. We had created the first Provider Fast Track form, and since then we have changed the form a number of times, and we'll be talking about that when we talk about the overview of the form. We standardized the referral process. Now we have dedicated Fast Track staff who are always reviewing the Fast Track referrals as they come in, and then making the assignment to the mobile crisis team or providing the alternative. So we have really experts who are doing the Fast Track now. We've also added options for providers and professionals. It's easier. You can fill out the form when it's convenient for you, and then send it when you're ready. You don't have to wait on the phone. And also the comprehensive information provided on the Fast Track form really enhances the client service. The mobile crisis teams have really felt that the information provided is very comprehensive and useful to them. So I also want to talk a little bit about the enhanced and current information available on our MHA-of-NYC.org website. So we ask you guys to go to the MHA-of-NYC.org website. Under the Crisis Services page, you'll find the link to the Fast Track form, and you'll also find the link to the referral guide for providers and other professionals. In the referral guide for providers and other professionals, you'll find all the details that we'll be talking about today about eligibility criteria, what are the different types of mobile crisis teams, and other helpful information. In addition, we have the most current version of the Fast Track form, which we'd like you to use, because each time we revise the form, it becomes better. So it's really important for us that you use the most current version of the form, so please go to our website each time you want to make a referral and open up the most current version there. We will also be upcoming, we'll be changing our fax number. We'll be having a toll-free fax number that'll be coming soon, and we'll have that information up on the website when that happens. Okay. Any questions for this section? Okay, we'll move on. Okay, I'm going to turn it over to Diana, who's going to talk about the hours and contact information.
Okay, the hours of the Fastrack service are Monday through Friday, 9 a.m. to 4:30 p.m. You can call 1-800-LifeNet to make a MCT referral outside of these hours. You can contact, Gail Bauer or Lynn Kaplan. If you have any questions about the referral that you're about to place, you can also call us at 212-614-5742. If you have questions before you fax your referral, you're more than welcome to give us a call or email.
Great. Okay, so we're going to move on and discuss the eligibility criteria for mobile crisis team. Just to start out, what is a mobile crisis team? So a mobile crisis team is an interdisciplinary team that will respond to people in the community, usually in their homes. The services include assessment, stabilization, and linkages. And just to mention that the Children's Rapid Response Team responds to children within 2 hours in the home or at their school. And we'll be discussing that more in a few moments. So for mobile crisis team, the referral criteria is that the client is experiencing or is at risk of experiencing a psychiatric or psychological crisis requiring mental health intervention, and the client is currently not engaged in mental health treatment and is unwilling or unable to seek psychiatric services on his or her own or with the aid of a family member or friend. Or the client has been discharged from an urgent level of care, such as Comprehensive Psychiatric Emergency Room Program, CPEP, Emergency Room, Inpatient Unit, Medical Emergency Unit, and or are being followed by a Psychiatric Discharge Monitoring Program, such as COSCINAS, and requires mobile crisis services for the purpose of facilitating the individual's community tenure while waiting for the first post-discharge visit with a community-based mental health provider. Or the client is experiencing or is at risk of experiencing a psychiatric or psychological crisis requiring mental health intervention and is currently non-compliant with mental health treatment and is unwilling or unable to continue obtaining psychiatric services on his or her own or with the aid of a family member or friend. And most importantly, to consider when you're going to make a referral is that the case does not qualify as being at immediate risk to require an EMS referral. So that's for mobile crisis team. The referral criteria for the needs-adapted mobile crisis. So first, what is the need-adapted mobile crisis team? The needs-adapted mobile crisis teams are enhancements to existing mobile crisis teams. They offer standard MCT services such as assessment, stabilization, and linkages, and they offer psychotherapy, peer support, medication, and family therapy as often as needed for up to 1 year. The referral criteria for need-adapted mobile crisis team is that the person is experiencing a psychosis-related crisis, could be affective or non-affective, meaning that they either have a mood disorder or they don't have a mood disorder. For Parachute NYC Brooklyn, the client must be experiencing their first mental health break and not have been treated longer than 1 year. They don't have to have psychosis. The client must be age 16 to 30 years old, that's for Brooklyn. For Parachute NYC Bronx, the client must be 18 to 65 years old. For Parachute NYC Manhattan, the client must be 18 to 65 years old. For Parachute NYC Queens, the client must be 18 to 64 years old. They must be a resident of the borough that the need-adapted mobile crisis team is located, such as Manhattan, Brooklyn, Queens, or the Bronx. They must voluntarily seek or accept services. Now, that's not to say that they need to be voluntarily at the outset. LifeNet can still make referrals for clients who are unwilling to access services, and the consent can be established by the need-adapted mobile crisis team, so meaning they will go out and try to encourage the client to accept the services. The client must have permanent housing, not be homeless. They must be able to have a family member, or it could be a close friend, engage in treatment with them. They must be medically stable, not have dementia, not have traumatic brain injury or organic brain disorder. So that's for the need-adapted mobile crisis team. For the Children's Rapid Response Team, I'll just talk about what that is for a moment. So these children, the Child Rapid Response Teams, were created in response to too many kids being sent to the psych ER via 911 while at school. The Children's Rapid Response Team provides rapid response and short-term crisis management for children and adolescents in active crisis situations. They serve children birth through just before they turn 18. So the referral criteria for the Children's Rapid Response Team are that the child or adolescent must be experiencing an acute behavioral or mental health issue, such as behaving in a threatening manner, experiencing a current psychiatric crisis, displaying active symptoms of depression, suspected of drug abuse with the above situations, suspected of being bullied or perpetrator of bullying with the above situations, experiencing or is at risk of a psychological crisis. They must reside in the assigned community districts in the Bronx, Brooklyn, or Queens. The Bronx Children's Rapid Response, they respond to the entire Bronx community and every public school in the Bronx, including charter schools. For Brooklyn and Queens, the child must reside in the community district or the public school must be within the assigned community district. And just to mention that we now have the Manhattan Children's Rapid Response Team and Staten Island Child Rapid Response Team coming online, so we'll have more information about that soon. For the Children's Rapid Response Team, the child can already be connected to mental health services. For school, I mentioned before that the teams respond to either the home or the school, and for the school, we do need written or verbal parental consent. That's what I said. If the provider wants the team to visit a school, the school must call in the referral to give consent for the team to enter their building and provide intervention. So you need not only the parental consent for the schools, but you also need the consent of the school for the Children's Rapid Response Team to enter the school building. Okay. Any questions on the referral criteria? Okay. So if not, we'll move on, and I'm going to turn it over to Gail to talk about the Fastrack referral form.
Okay. So the Fastrack referral form was developed to capture information necessary to assess the client's eligibility and for the team to understand the client's current circumstances. We've revised the form a few times since we first started in February. We've made it more user-friendly, laid it out in a way that we are capturing the most accurate and needed information. And we've revised it using feedback from providers and professionals, from the teams themselves, and from our staff. We just updated the form again, made some significant changes, and that form will be uploaded to the website either today or tomorrow. And moving forward, we will revise the form quarterly. So the form is a mixture of checkoff boxes and narrative boxes. The checkoff boxes offer the opportunity to quickly relay a lot of information, whereas the narrative boxes help put the checkoff boxes in context, really help you describe what's going on. So let's have a look at the form a little. So we start at the top. This is the first page, and we very clearly state that, you know, if you believe that this is if the client is at imminent risk, then 911 is more appropriate, and we do not want any referrals sent on our off hours because we want to make sure that the client is receiving the most appropriate services, and we don't want any delay. So outside of the referral hours, we would ask that the referrals be called into LifeNet, which is 24 hours. So we ask that you check off whether or not this is a new referral, or if we've spoken with you and ask you to make some changes, we would ask you to resubmit it, and then we'd ask you to check off if it's a resubmit. Some basic information, the date, client's name. If the client is a minor, we would need the parent or guardian's name and contact information, a date of birth, age, gender, language, all of this information. We certainly need the apartment. The team respects the confidentiality of the client and can't be walking around trying to figure out which apartment the client lives in. If there's a primary contact person, maybe this is a person that lives in a housing program, and maybe the manager is the person to reach out to first, then you could put that here. Then we need your information, your name and phone number, your relationship, therapist, caseworker, and email address. This is another way for us to make contact with you if we can't reach you by phone. Then we have 3 options to describe where you're calling from, either a behavioral health provider or a hospital, an agency if you're from ACS or a shelter, and then a school. For schools, we want to know the dismissal time. That helps us figure out whether or not we're going to be asking the team to respond to the school or to the home. We ask that you be available for an hour after you submit the referral in case we have any questions. If you are not going to be available, we ask that you provide the name of someone who not only will be available, but can answer questions specific to the client's current circumstances. Okay, on the second page, we ask a few basic questions again. How to get in touch, when is best to get in touch with you, if the team has been out before. Here's an important one. If the client is a minor, we need to know if the parent is aware that a referral is being made, and if the school is calling, we need to know if parental consent has been obtained. In this section, we have an appointment time here. This is for people that are calling in either from a behavioral health or substance use disorder clinic, clinicians who work with the client, or someone in an inpatient psychiatric unit, or someone in a CPEP. People that have access to making an appointment, we ask that they provide us with an appointment. Because when the team goes out, they want to give the client an upcoming appointment time and encourage them to attend, and then they keep in contact with the clinic to make sure that the client attended the appointment. Then we have some information about the clinic, the name, therapist, whether or not the person is new to the clinic. This is important. When the behavioral health or alcohol substance use disorder provider last saw the client, this helps us understand, how estranged the client has been, how current the information is. So it might be that you haven't seen the client for 3 weeks, but maybe you spoke with the client over the phone yesterday. So that would be, last date of other contact. Or maybe the client left you a message over the phone, or the parent reached out expressing concern. So that would be the last date of contact versus when the client was last seen in the office. Then we ask some questions about psychiatric hospitalizations, inpatient detox, and inpatient rehab specific to the last 12 months. We want to know how often and what time period those inpatient stays occurred. And then a question about a psychiatric advance directive. All right, then we get into who's in the home. Are there children or adults in the home? And are there other agencies involved? Is ACS involved or APS? That, again, helps us understand the circumstances of the client. And a little bit about legal information towards the bottom. And then we'd like to know if there are weapons in the home or dogs. This is regarding safety for the team that's going to be visiting, but also if someone is having thoughts of killing somebody else and has access to weapons, that helps us assess the severity of the situation. Okay. And then any information that you think the team might need to know. Is the client's apartment around the back down 3 steps? or is the bell not working? Something that will increase the chance of the team finding the client. So anyone that's familiar with the form over the last few weeks will see that this section has changed over time. We've tried to set up the narrative boxes so that we're eliciting the most information possible, the most details, and making it as clear as possible. In the first box, we ask what's currently putting the client at risk. Has there been any changes in the last 3 days related to their behavior or functioning? So this is where you really get to say why you're calling and why you're placing a mobile crisis referral today. What's going on for the client? And it's very helpful to know specific details, dates of when incidents are happening. So if you were to write something like, the client threatened his mom and ran out of the house and didn't come back for 3 hours, that's certainly concerning, but if that happened 3 weeks ago, that's different from if that happened this morning. So having specific dates as to when things happen, if the client has attempted suicide in the past, it's helpful to know if it was last week or 3 years ago. The reason the mobile crisis referral is being made today. Oftentimes there's a reason why you became concerned today. Is it because the client missed the 3rd appointment in a row? Is it because the client left a very concerning voicemail overnight, or the client's boyfriend called expressing concern? What's been going on, and what made you call today? The third box is the client willing or able to seek treatment. If the client is willing or able to seek treatment, we would then talk to you about whether or not it's sufficient for us to just give you some outpatient some outpatient mental health clinics. If there's a reason why the client is not making it to appointments, maybe they do not feel that they need it because they don't think they have mental illness, or maybe they haven't attended the last 3 appointments because they relapsed. It might just be something as simple as they've missed their last 3 appointments and haven't returned despite multiple attempts to outreach the client and letters home. So just an understanding as to why the client is not engaged in treatment at this time, if that's the case. Okay, at the bottom we have a physical description of the client, including ethnicity. It may be that the client is hanging out outside the building, or is, hangs out on the corner, and this might just help the team kind of figure out who the client is. It can be very helpful. Please remember, if you have any questions, just type them and I'll certainly address them. Then we left a box for where you can just add any information that you think is pertinent to the referral, the last 2 months, any circumstances that have occurred that you think is important for the team to know. So back to checkoff boxes, this is a way for you to just give us a quick sense of what's going on for the client. What are the presenting concerns? And we ask that you refer only to the last 2 months, since the mobile crisis team does address current crises. So you can check off whatever's applicable to your client's circumstances. At the bottom, here on the bottom right, if the client is missing appointments, we ask that you click, and this will allow you, it doesn't work right here, but you would click on here and a calendar would come up and you can select the actual date of the appointments that the client missed. And if there's something that we didn't think of, you can just put it right here in other. Okay, so notable impairments in performing daily activities. Not only, it might be that the client is not coming to appointments, but how is this impacting their ability to get through the day? Are they not showering or not eating? Have they stopped going to their job? So this just helps us better understand the kind of a whole puzzle of what's going on for the client. this is one piece, sorry, of the puzzle. Okay, again, this page of the form has been changed to make it as clear as possible and help us understand the possible imminent risk for the client, suicidality or potential for self-harm. We ask specific questions about, are they currently having thoughts of suicide, have they had thoughts in the last 2 months, and have they ever attempted to kill themselves? And then also, have they, in the last 2 months, attempted to hurt themselves by cutting, pinching, self-injurious behavior? This really helps us understand how at risk they may be, in addition to all of the other information you've provided. If you do answer yes to any of these questions, we then ask you to fill out other information that kind of gives details. You know, if they attempted suicide, when did they attempt? How did they attempt? If they're having thoughts of suicide right now, are they having suicidal desire? Are they having, is there an intent to commit suicide, and the capability? All of these things really help us assess the client's current risk. Now, we understand that sometimes you may not know all of this information. Sometimes you may barely know the client, and we get that. And we just ask that you put that somewhere on the referral. You know, this client was referred to me last week. He hasn't turned up, but based on his referral packet, I'm very concerned about him, but I don't know if he's having any thoughts of suicide. That will help explain why that section's blank or unknown. So similar to the suicidality page, we have, we're trying to assess the client's homicidality or potential for harming others. We ask about their current thoughts of killing or harming others, whether they've had those thoughts in the last 2 months, and if they've ever physically harmed or attempted to kill someone. And again, if you answer yes to any of those questions, we ask that you describe whether the client has any desire, intent, or capability to harm others. And then it's also important to understand what risk factors the client has. Someone who has chronic mental illness, abusing substances, and is isolated may be at greater risk than someone who has none of these risk factors. So these all just help us gauge what's going on. And on the flip side, protective factors. What is maybe preventing them from following through on their thoughts of suicide? So all of this is very helpful. We're nearing the end. Now we're at the, we want to get a sense of their alcohol and substance use, whether or not they are using or have in the past. We ask about the behavioral health or substance use disorder diagnosis. And if you don't know the specific name for it, you can just put that they use alcohol. And then a little bit about their active psychiatric medication, whether or not they're taking it as prescribed, whether they're out of medication. And the same for active non-psychiatric medication. And also any medical issues that they may have. And if they do have an acute medical condition, we ask for the treating medical provider. And then lastly, we ask for the health insurance information, which is important since some of the teams do bill. Okay. Just a couple points. When completing the form, it's important to fill in as many of the boxes as possible to avoid any delay in processing the form. Consistency is important. If you mentioned in the narrative box that the client has had three suicide attempts, but then under the suicidality page it says no suicide attempts, that's going to mean us giving you a call to clarify, and we don't want to delay assigning a team. Okay. So that's it, and feel free to write any questions. So that was the form. Then we also have the sample form that we had sent out to you this afternoon that I'd filled out with oh gosh, I'm forgetting the word, not mythical.
Fictitious.
Fictitious is the word. A fictitious person, Ellen Smith. Again, very self-explanatory, but a couple points I want to make is that the appointment is there. That there's an appointment within the next 3 to 5 business days, since this is a mental health provider making the referral. And that in the narrative boxes, it clearly gives you a sense of what's going on, what the risk is. It gives you specific dates, describes, we don't have it on the screen, but it says,
Since we're recording it, maybe you would want to read it. That
Yeah,
way would,
that makes more sense.
Yeah.
Thank you. So for the question, what is currently putting the client at risk? Has there been a change in the client's behavior or functioning in the last 3 days? The narrative reads, during the April 30th session, the client reported a recent relapse with alcohol due to increased depression, recent breakup, and job loss in March. She reported a decrease in appetite and isolation from friends and family. So that really explains that this client is, her functioning is decreased by her alcohol use and her depression. This is also someone who has missed 3 appointments, so now she's not connected with treatment. The reason for the mobile crisis referral being made today, the narrative reads that I request the team to assess the client and help re-engage her with treatment. It's unclear if she's still taking her medication. Client has had a history of 3 suicide attempts related to past relapses. She's a high-risk client and ongoing treatment is crucial. So the fact that she has relapsed is concerning enough, but then for us to read and know that in the past when she's relapsed, she's attempted suicide, it just makes it that much more concerning. Okay, I don't know that I have any other, specific points about the form, but we sent it to you so that you can see one filled out appropriately and give you an idea of how to do the narrative section. Now I just want to go over the Fastrack referral process. When we receive a referral, it comes through eFax, we read it, and we are looking for key things. We're trying to, first we want to make sure all the pages are there. We want to make sure that all the boxes are complete and that it tells a real story and we're able to understand what's going on. If there's any question as to what's going on or if there's something big missing, like an entire narrative section is missing or the address is missing, we'll call you right up and ask you to resubmit the form with the missing information. If there's something small missing, like we just don't understand when you last saw the client, we'll call you up, ask you that information, but we won't have you resubmit it. Once we've determined that the referral is appropriate, we will assign it to a team, and we'll call you and let you know the name and number for that team. And then we will fax it to the team. You do not need to reach out to the team at that point, but we always give you the phone number. That way in a day or so, or 2 days or so, if you haven't heard from the team, you can reach out to them for an update.
This raises a question in my mind. My staff sometimes refer to mobile crisis. Sometimes we meet people briefly and have interactions with them. We know they need the service, but we don't necessarily know all of the information that's required on the form. How important is that, or what do we do in those cases?
No, that certainly comes up. We ideally would love every box to be filled out. There's key things that we have to have, the address, the person's name, and then we need to have an understanding of what's going on. If you know the information, please put it. It just speeds up the process. If you don't know it, just explain why that is, and we completely understand that. We certainly don't want any delay in getting the team, and we don't want any barriers to connecting the person with the team. that brought up one thought with the referral. Sometimes people submit referrals and specifically state that they want the child rapid response team, and then they are surprised when we assign it to maybe Kings County or VNS Queens. And this may happen because although it's nice to imagine a child-specific team responding to a child, the rapid response child teams have very specific criteria. So it may be that your particular client didn't meet the criteria. There has to, like Lynn had said, there has to be an acute crisis. It has to be within the last couple of days. This can't be a chronic issue. So although you may think that the child team is appropriate, we assess the referral and assign it to the most appropriate team.
Great. Any other questions about the overview of the form or the Fastrack referral process before we continue? Yes?
I had one that occurred to me. We document on the form any known substance abuse or relapse issues. It's not uncommon to have a concern because substance abuse is very heavy, and that can cause someone's life to be at risk, and that could be a concern. What if that's really the presenting problem and it's not really accompanied by other known thoughts of suicidal ideation or other kinds of decompensation?
Sure. So we need to have something that's putting the client at risk, psychologically, any type of psychological crisis. But that does not exclude substance abuse. So if you have somebody who's using substances, but they're also, for example, not taking care of themselves, they're not showering, they're not eating, they stopped going to work, so they're not functioning, they may be having suicidal thoughts or thoughts about harming someone else, that's a very appropriate referral for a mobile crisis team. What wouldn't be appropriate for substance abuse is cases where we really do want to help someone, but our hands are kind of tied. For example, you might have someone who's using substances, but they're actually managing to continue to go to work, they're eating, they're not expressing any suicidal ideation, they're not doing any behaviors that would cause us to say they're putting themselves at risk. And even though we want to help that person, they're not appropriate because they're not showing themselves at risk where a mental health intervention is needed.
Okay. And if the person has a problem and just won't accept treatment, this can't be used as a way to encourage someone to accept treatment then?
Not just for substance abuse, unless they're putting themselves at risk.
Got it.
Right? And then they can certainly have substance abuse and then other things that are putting themselves at risk where they need the mental health intervention, but if they're not putting themselves at risk and they're primarily only using substances, unfortunately, there's not a way that we can intervene with mobile crisis. But we certainly welcome any calls to either the Fastrack team if you're concerned, or call to 1-800-LifeNet, where we could help you find some alternatives that may be able to help. So it's not that we can't help at all, it's just that mobile crisis isn't appropriate at that point. Yeah.
That makes sense.
Okay, any questions from people online? Okay, so we'll move on to Diana, who's going to talk to us about alternatives when the client doesn't meet criteria for mobile crisis referral.
Okay, and on that note, there are times when your client will not meet criteria or MCT is not appropriate, and I'm going to describe some of the situations that might fall into this category. If you're seeking psychiatric evaluation only for your client, mobile crisis is not appropriate for this type of service. The LifeNet counselor or the Fastrack counselor can provide suggestions or alternatives on clinics to provide for your client. If the client is in crisis, the LifeNet counselor or Fastrack counselor can conduct crisis counseling and risk assessment. We'll do that with you over the phone and see what would be most appropriate. If the client is in need of a psychiatric evaluation, we can help you, we can recommend psychiatrists through either outpatient clinics or through the client's insurance, or just let you know to help the client call their insurance and see if a psychiatrist would be available to that. Let's say you cannot find your client, you don't know where your client is, referral source yourself does not know where he's located. MCTs are not designed to provide client locator services. the provider will be advised to call in a missing persons report for your client. Let's say your client is in need of case management services. He's not at risk, and it just needs linkage to treatment. If yourself, you indicate the client is not at risk but needs to be linked to services, MCTs are designed to respond to individuals who are experiencing or at risk of experiencing a psychological crisis that may require involuntary transportation to a psychiatric emergency room for a second evaluation. Thus, linkage services are not appropriate at this time. But let's say that's what you're looking for. We do have a database, and we will be able to help you look into what case management agencies you might be able to refer your client to. Let's say your client is in need of prescription medication. He or she has run out. LifeNet will encourage the caller to go into the nearest, not the caller, but your referral source, to encourage their client to go into the nearest psychiatric emergency room. If they've run out of medication, MCT services are not appropriate for this situation. Let's say if the client does not have health insurance, LifeNet will encourage the client to go into the nearest HHC hospital where they can receive services regardless of insurance, and we will be able to let you know which one is the closest one to your client's home. Let's say your client cannot get an appointment, there's a long waiting list. MCT services are not appropriate for this issue. This may be due to a significant waiting list at the clinic. Teams are not capable of bypassing clinic's wait list. Where possible, LifeNet crisis counselors can provide you with information to walk-in clinics. So we'll do that over the phone. If you provide a referral where your client cannot get an appointment, we'll help you see what's the closest walk-in clinic. Let's say the chronic problems, not mental health related. Again, the crisis counselor that calls you back will be able to help you find appropriate referrals for your client.
Okay, any questions about the alternatives when the client doesn't meet the criteria for the mobile crisis referral? Okay, any questions about that? Okay, so we'll move on to moving forward. Okay, so moving forward, we're actually going to be instituting the online submission of the Fastrack form. So we have a computer system where we enter all our data when we get either Fastrack referrals or also, for callers to LifeNet. And what we're going to be doing is we're going to be having the link on the website, and you'll be able to open that up, and when you enter the information for Fastrack, it'll actually be submitted right into our database, which will be a one step, faster even for this service. So it'll be even more streamlined. So that's coming. Again, when we have information about when that will start, we'll put that on the website. And just to let everybody know that we're also developing a new 1-800-LifeNet.org website. So many people may or may not have tried to use our current website. It's not so user-friendly for searching for referrals and not so user-friendly in general. We are creating a new, and I think it's going to be excellent, website, which will have the same search functionality that our crisis counselors have. It'll have the exact same database, so you're going to be searching in the same database as our counselors, for the same referrals. So that will be great. And I think the way we've designed it, we're going to have a lot of information. There will be a link on there eventually for the Fastrack form as well. So you'll be able to submit it online through the new website. And there's also going to be information not only about crisis services, but information for anybody wanting to get services from themselves, a provider wanting to get services for a client. There'll be information about coping and wellness. So I think it's going to be a very useful website. So we'll also let people know, we'll do some publicity for sure around that when we get that launched, and we're expecting that kind of end of June to be ready. So look for that. And as I mentioned before, we're going to have a new toll-free fax number for Fastrack referrals, and we'll put that, we'll obviously put that on the form. We'll once we have it, we'll put that on the new form, and that will be up on the website. And we'll also put an alert on the website that there's a new fax number. So those are a few things for moving forward. And now, really, it's time for getting your feedback. Of course, any questions about the presentation or questions in general about Fastrack or mobile crisis services. And then really want to get your feedback about the provider Fastrack and, other things that you may want to give us feedback about in terms of this process. So, yeah, so if you guys want to either write in your questions, or since there's only, there's two of you on the line there, so we can, if you want to unmute your phones and ask your questions, either way, chat them in or ask them, that's fine. Do people have any questions?
Andrea's typing.
Oh, excellent. Okay, let's see. I'm just concerned when there's no way to schedule an appointment for a patient. I've had referrals rejected in the past due to this.
Yeah, I can imagine that can be frustrating, but it's something that really enables the team to help re-engage the client immediately. When the team goes out and meets with the client, if they don't have an appointment already, it can take a lot of time for the team to get in touch with the provider, a lot of back and forth, and that just can lose the opportunity to engage the client while they're in the client's living room. So if they walk in and they have an appointment right there, they can provide it to the client.
So, and Andrea typed again, sometimes the client has never engaged and doesn't want to engage. And Andrea, can I just ask, are you working in an outpatient clinic?
Hello.
Hi, are you working at an outpatient clinic?
You see, right now I am working in a psychoanalytic institute, and there may be less need for this service, but I came from an Article 31 clinic where we had probably more need for these types of services, and sometimes we would have situations where a patient would call us on the phone. They were so inappropriate for our facility, they most certainly needed a higher level of care, and we felt we needed to get somebody to them. It wasn't a 911 situation, and it would be ridiculous for us to have provided an appointment for the patient. At one point during your seminar today, you had said, we don't want anything to stand in the way of getting help to the patient. And that situation had occurred on more than one occasion where we could not, in our right minds, give a person who really needed hospitalization an appointment for an intake. You needed to be...
Sure, go ahead, sorry.
He either needed hospitalization or needed a MICA program or needed, a program that's different from ours, a PROS program. You would have wanted us to give you an appointment time for an intake for a patient that we felt just from the conversation on the phone would probably not be a patient who would end up with us. So we'd give an appointment, patient would come, then we wouldn't accept the patient, and we would refer that patient to a more appropriate level of care, something that was much more suited to the patient's needs. We wasted a lot of time.
So maybe I can respond. So I was actually the director of the Interfaith Mobile Crisis Team I worked there for about 20 years, but I was a director there for 17, 16 years or something like that. And actually, I came up with asking for the appointment because what would happen is that we would get referrals from outpatient providers, and then we would have a really hard time after we saw the client, getting in touch with them to get the client back in. And it's really important once the team sees the client to have a quick appointment, because that really helps the person to kind of re-engage. And just, I hear what you're saying definitely about the higher level of care and feeling like that client just will never engage with your services. What's important to know is that the mobile crisis team is a service to intervene, to stabilize the client, and relink them to treatment. It's not, for example, a referral on its own. So it's important to know that even though it seems to you, the person really doesn't belong in my clinic, the person needs a higher level of care, or they probably really don't want to come, it's really important to know that the expectation for the team, because they get so many referrals, is to really assess the client if they need to hospitalization or not, stabilize them, and then relink them back to the outpatient clinic, who can then, of course, make that decision to, transition them into a higher level of care or a different level of care for what is appropriate. So that's really the reason why we asked for the outpatient clinic, because the teams otherwise would end up with such a large caseload of clients that they wouldn't be able to do their really quick response time, which they do. So we just need to get them back to the clinic, and then the clinic will then transition them if they're not appropriate for that level of care. Of course, if they need hospitalization, the team will hospitalize them, when they get there. They would not, they were not going to send them back to you if they need hospitalization. Does that help?
It does help. Unfortunately, my memory is not, I can't come up with situations, but there were other types of situations where it didn't make sense. But I'll also say that there were many times when we certainly were willing to schedule an appointment, but it always seemed like a struggle. It always, I think maybe a paper process is better. It just seemed like a struggle, no one seemed to want to accept the cases. Now, I mean, I came from an outpatient clinic setting. I'm sure you get even more referrals from higher levels of care than us. We weren't, if we called mobile crisis maybe once a month, maybe twice a month, it was a lot. But it always seemed like it was going to be a real tough negotiation to get the cases accepted.
So I want to let you know that if you have that experience, again, please don't hesitate to reach out to Gail or myself, or to call the Fastrack number if you feel like a case has been rejected, when it shouldn't be rejected. We are really wanting to reduce barriers, and we may help figure out the reason and figure out an alternative, or we may hear something, talk with you and really see like, no, this really is an appropriate case. So please contact us if you feel like a case is ever rejected in error.
I will. I definitely will. I mean, I think it's good that you have this now sort of paper version. It also was very time-consuming because you'd call LifeNet. LifeNet would take all this clinical information, and then if they accepted the case, I mean, you had to get them to accept the case, and then LifeNet would refer it out to the mobile crisis unit. Then the mobile crisis unit would call you, and you'd have to basically have the same conversation over again.
Sure.
Very, very time-consuming and frustrating.
Right. I think this is a better process because we're collecting a lot of good information. And I actually should have mentioned another thing that we're working on. And Miriam, we're going to get to your comment in a moment. Another thing that we're working on is actually a decision tree, which is going to be helping people even before they refer to see whether it's appropriate for, is it a 911, is it an immediate crisis that we need 911 intervention? Is it appropriate for mobile crisis? Is it appropriate for something else, and they should call LifeNet? So we're going to be, we're going to be also, we're working on that. We're going to be incorporating that as well to help people. And that will be also available on our website, but we're still working on that, but that will also, I think, really help things.
That sounds really good.
Okay, Gail's going to go up and read Miriam's comments.
Sure, I'm going to mute myself again.
Okay, thank you. And thank you for your comments, please.
Sure.
Hello? Oh, sure. Sorry, just going to move it up. Oops, okay.
Okay, so Miriam said, though it was mentioned, I just wanted to reinforce the importance of speaking with the legal guardian for consent for the referral of a minor. It has, so Andrea, let me just explain. Miriam is a supervisor coordinator, sorry Miriam, at a Children's Rapid Response Team in Brooklyn. Okay.
Oh, I have to go back up, sorry.
I just wanted to reinforce the importance of speaking with the legal guardian for consent to the referral of a minor. It has been my experience that providers have not always had the discussion with the legal guardian, and this has an effect on the success of the legal guardian consenting to the Children's Mobile Crisis Team services when we arrive to the home. It is the providers that have a relationship with the families and can reinforce the benefits of this, leading to more success for engagement in services. And Miriam's the program coordinator. Thank you. Okay.
Okay, thank you very much for that. That's an important statement, so thank you for that, Miriam. Okay. Other questions that have come up? Okay. Anything that anyone else has thought of while we're talking that we didn't mention?
I don't think so.
Okay. Okay, so if there's no more questions, then we'll just go ahead to our last slide, which is thank you. And thank you for joining us. And we're going to be, as I mentioned before, we're having another Fastrack online video conference next Wednesday, the 27th at 3:30 p.m. So if you know of anybody, if you could forward the invitation to them, we're more than happy to welcome other people to that conference. And we're planning to have these video conferences probably every other month going forward so that we can continue to educate people and get people's feedback. And that'll be really important also as we go forward and are reviewing and revising the Fastrack form quarterly. So thank you all. And that's it.
Thank you.
Thank you. Okay, goodbye, everybody.